Hello, everyone. I hope you are all keeping so well out there, and welcome to today's webinar. We are going to focus on the latest advancements in periorbital rejuvenation, combining the very latest innovative EMFACE eye applicator and injectables. Our expert panel, including myself, will guide you through a detailed exploration of the anatomy of the periorbital area, the impact of aging, and how these powerful treatments work together to restore youthfulness around the eyes. From muscle toning techniques to the seamless integration of EMFACE and injectables into clinical protocols, you will gain valuable insights into enhancing your practice and achieving superior natural-looking results for your patients. We are all excited to have you, over 900 of you globally, join us for this informative session today. I hope you enjoyed this session. So good evening, everyone. My name is Ms. Sherina Balaratnam. I'm from the UK, and I am joined together tonight for two amazing panel speakers of mine. So a little bit about what's happening today. We have got three amazing speakers, and we're going to be discussing all things periorbital area. This is an intricate area that all patients do come to us requesting treatment, requesting results as safely, effectively, and naturally as they can, and as weak as practitioners can deliver. It requires a great understanding of the anatomy. It requires an excellent knowledge of aging, and it requires expert skill when combining injections together with energy-based devices to ensure that they receive these results. So our esteemed panelists are going to share their insights on what makes this area particularly challenging, but also particularly rewarding to address the common concerns associated with it. I would like to start with our first presentation delivered by Professor Sebastian Cotofana. He will begin by examining the intricate anatomy of the periorbital area, as well as his aging processes. Professor Cotofana will be highlighting muscle toning as a key strategy to counteract these changes. Next up will be myself, and I'll be talking to you my why on why I've introduced EMFACE eyes into my practice. And finally, renowned dermatologist all the way from the USA, Dr. Melanie Palm, will be sharing her experience combining injectables in the periorbital area together with EMFACE eyes, and how she seamlessly delivers her protocols in order to restore beautiful results to her patients. So let's get started, ladies and gentlemen, and enjoy. It gives me great honor and a privilege to introduce the first speaker for today, Professor Sebastian Cotofana. I've had the privilege of learning from Professor Cotofana on webinars all around the world, to his anatomy teachings as well. He is a recognized global anatomist, world's leading anatomist in the field of facial aesthetics. Many of you are going to be familiar with him. With extensive research and expertise, Professor Cotofana is one of the world's sought-after speakers and influencers in aesthetic research worldwide. And he holds multiple honorary professorships at Queen Mary's University in London, England, as well as the Pirogov University in Moscow, Russia, and in the Department of Plastic and Reconstructive Surgery, Guangdong Second Provincial General Hospital in China. I'm honored to introduce Professor Cotofana to you.
Sherina, thank you so much. That was very kind, and I'm really sorry for this long introduction of all of these accolades. But guys out there, we're really happy to have you for this webinar, and we're going to share some amazing new insights, not only on anatomy, but also on the new technology and how this will help your clinical practice and how this will help your patients to achieve superior outcomes. And unfortunately, to understand this better, you need to know anatomy. I'm really sorry about this. This is kind of like, most of you have thought, well, after medical school, I never need to hear about anatomy again. And voila, you are here back again listening about anatomy as it is relevant and as it pertains for your treatments. So let's get started on this presentation, which of course, multiple information can also be found here on Cotofana Anatomy, where you can find significantly more on this one. And the topic today is periorbital anatomy. And periorbital anatomy, I structured my talk into supraorbital and into infraorbital, because these are two different things, two different compartments with two different aesthetic needs that you need to consider. I have nothing to disclose because I'm presenting on anatomy and on the respective underlying research results, but I would kindly ask you, do not take pictures or videos of the donors of the anatomic content, because it's about respecting donor privacy. Those who did anatomy courses with me, you know exactly, I'm always at the beginning of the course make you aware of what to take care of these respective aspects. So first topic is supraorbital, and for supraorbital we're going to review the intricacy of the respective anatomy by looking at this. This exposes the frontalis muscle. Frontalis muscle, very important because it sits within a sleeping bag. On top of the muscle you can see some whitish fibers, that's the coverage of the respective sleeping bag, and on the underside you can see this other fascia there, that's the underside of the sleeping bag. So very important to understand the effects of the forehead applicator. These are the two respective supraorbital and supratrochlear neurovascular bundles which give rise to the respective arteries and nerves. And now I'm pulling back up the flap that I just raised, and I'm elevating the frontalis muscle, and this makes you see significantly better the subfrontalis fascia. This makes you understand that yes, the frontalis muscle is truly in a sleeping bag. There is fat located between the frontalis muscle and the subfrontalis fascia, which I'm grabbing right now, and you can see that this fat is continuous into the upper eyelid. This fat that you just saw is referred to as preseptal fat because this fat is located anterior to the septum. And once we cut through the septum and go deeper, then we can find another muscle which is very important for elevating the eyelid, which we call levator palpebrae superioris muscle. Now, as we move on with my presentation to the next slide, I would like to remind you that the treatments, independent if we're focusing in this webinar, just focusing on the periorbital region, they are co-influenced by also treatments of the forehead or of other facial regions because they are layers, and these layers connect the respective regions with each other. And if you look at this layer dissection, you might be surprised how many layers there are in the forehead, and then how these layers transition down into the respective supraorbital region. And you can also follow these respective layers coming from the forehead down into that area, and these layers can also be found with ultrasound. Most of you have ultrasound in your clinical practices, and you can just apply this knowledge and continue with identifying the respective layers, which are important. But there's a couple of things that you need to consider, especially when we're talking about the upper eyelid. On the upper eyelid, if we do a layer by layer dissection, it is important to understand what comes after the skin and what follows deep to the skin. So first of all, we do have the skin. After that, we do have the orbicularis oculi muscle. Below the orbicularis oculi muscle, we have a layer of fat. That is this fat that I termed in this area here as preseptal fat. It's referred to as preseptal fat because it lies anterior to the septum. But this fat can have different extents. It can have different sizes, and along with also fat that is located deep to the septum and anterior to the aponeurosis of the levator muscle, which we then call pre-aponeurotic fat. And the best way to understand this is if you look at this cross-section. This is from another publication that was published in 2015. And here you can see in the histological analysis, you can see the skin and you can see the orbicularis oculi muscle. That's referred to as OM. And then you have the asterisk. The asterisk indicates the fat between the muscle and the orbital septum. That's because it's located anterior to the septum, it's called preseptal fat. And then with the triangle, it is marked the fat that's located behind the septum and anterior to the levator aponeurosis. And that's because it's anterior to the aponeurosis, it's called pre-aponeurotic fat. And the balance between these two fats, this and the size and the extent of this respective fat, is influenced by age, by gender, and by their respective ethnic background. And the combination of these two fat pads, they also influence the formation of the upper eyelid crease. Some have a very extensive, very deep eyelid crease. For instance, in my case, I mean, my crease is very deep, very hollow. And there are some other instances where you have almost no upper eyelid crease. And this is influenced by the combination between these two fat pads. Again, preseptal, pre-upper neurotic. So here in this image, both of these fat pads are balanced. But if we move now, you can see here they are totally disbalanced, where the other one is slightly smaller. And if you look at this one, you can see how big the respective pre-upper neurotic fat is. And you can imagine this will ultimately influence the shape of the upper eyelid appearance. Very important to note, upper eyelid function is majorly driven by this muscle here, which is called levator palpebrae superioris muscle, which has a very important function of elevating the upper eyelid. Most of you know this, especially when you inject toxins, because that's like, hoo-hoo, I want to stay away from exactly this respective component. But we sometimes need to be mindful that, especially in this area, we also have some nerves. And these nerves, they emerge from the respective foramen, travel deep down, and then emerge into the other layers that you can appreciate here. And in addition to this, and unfortunately you can see this on the next slide, there you can actually see that you have anatomical variations, because sometimes these respective nerves, when they emerge from their foramen, well, they sometimes don't get through a foramen. They sometimes get to a notch, sometimes is the foramen significantly higher. This is unfortunately anatomic variation of the respective supraorbital region. Now we're going to move into the infraorbital region. And in the infraorbital region, I again want to follow with you a layer by layer dissection approach. So for instance, when we reflect the skin, you can expose the superficial fat of the midface. That's in a lower aspect. And you can see that in the lower eyelid, you have only a layer of connective tissue, and then the respective orbicularis oculi muscle follows. This fat, of course, is highly variable. In young individuals, we might have a little bit of more fat lobules, but in general, there is almost no fat in this area. In addition to this, the skin is also very thin. It's the thinnest skin that we have in a human body. And if you understand that the skin is very thin, you understand sometimes why we see the underlying vein or the underlying muscles, which present themselves as darkish discoloration, like the dark circles around the eyes. And in addition to this, a thin skin also has limited retaining forces. So that means they can retain and provide stability for the lower eyelid. If you move forward, you can see that the orbicularis oculi muscle sometimes is fairly large, sometimes reaches down until the midface. It continues with the midfacial mass. It's fairly large, this respective muscle. And at higher age, this muscle is interspersed with fatty tissue and fibers. So in other words, the containment ability of the orbicularis muscle is also reduced. So in other words, the skin is thin, it's weak. The muscle is sometimes thin and at a higher age, also thin and weak, and therefore reduced containment forces can be observed. But we still have the orbital septum, and the orbital septum contains all of the structures inside in the orbit, which normally we should do. And in addition to this, we also have the orbicularis retaining ligament. This ligament provides also additional stability for the orbicularis muscle. You can see here, I put ropes along the following of the orbicularis retaining ligament, and you can see how this ligament serves as attachment, and with this as stability for the lower eyelid, for the lid-cheek junction, and also for the respective orbicularis oculi muscle, as you can see here. In addition to this, we also have fat. We have fat like the SOOF, or like the roof, but the SOOF below, the roof on top of the orbit. And this fat and the volume of this fat also provides stability for the lower eyelid, for a smooth lid-cheek transition. You can see this beautifully here. This is a greater view, and you can see the different layers that we have. We have superficial fat in layer number 2, we have orbicularis in layer number 3, and we have deep fat in layer number 4, which is located deep to this area. But you can see something else in the slide. You can see the respective facial vein / angular vein that travels in this area. And if you do some CT scan reconstructions, you can see how the vein is located in relationship to the respective fat compartments of the infraorbital region. But the vein is one thing that I have to say that I was wrong. Because when I published in 2017 on the pathway of the facial vein, I mentioned that the vein travels within the supraperiosteal plane deep to orbicularis oculi muscle. Well, in 2022, I was proven wrong, because we found out with ultrasound measurements that the vein travels inside the muscle. Yes, inside the muscle. You can see this here, this graphic illustration. You can see how the vein travels inside the muscle. So it means the deep plane, there's no vein. And this is why we can, when we treat the tear trough with other soft tissue fillers, we go into the deep plane. Well, in this way, we can provide support, and also we can, in addition to this, recreate the position of the orbicularis retaining ligaments that provide attachment for the respective orbicularis oculi muscle and the respective intraorbital structures. Here you can see again the beautiful course of the vein traveling inside the orbicularis oculi muscle. But what happens if you reflect the orbicularis oculi muscle along with the orbital septum, which I did here in this dissection, and then you can see that there are fat pads inside the orbit. Inside the orbit there are fat pads. Sometimes they like to push against the orbital septum and the muscle, and normally septum, muscle, and skin, these three structures provide sufficient containment forces. And these sufficient containment forces, they allow for a smooth lower eyelid position, for proper apposition, for proper lower lid height, and of course for a smooth lid cheek transition. But if we now reduce these containment forces, so in other words, there is not sufficient support, then the intraorbital fat, the fat that's located inside the orbit that you just saw on the previous slide, that pushes against the septum, the muscle, and the skin. And if there's not sufficient containment force, then this allows for accentuated palpebromalar groove, for palpebral bags, and for a midfacial deflation, because it pushes everything downwards. So I think this is very important to understand, and how the anatomy is, and why containment forces are important for the lower eyelid, and why they influence the whole appearance of the entire periorbital area. Because you can imagine, when there's less support for the eye globe, then of course something happens to the supraorbital region. So in other words, the infraorbital region influences also the supraorbital region. And now we're coming to an end of my presentation, because that's only my part to update you on the anatomy, which you know anyway. But now we're going to hear the latest information about technology, and later on how this can be applied clinically, how this can be of benefit for your patients and for your clinical practice. And with this, back to Sherina.
Thank you so much, Professor Cotofana, for taking that deep dive into the anatomy of a very, very delicate area. I think as injectors, as well as energy-based users, it's really important to understand the critical influence of our treatments and where it's placed in the anatomy. It's great also to see how the anatomy is newer. You know, you're researching and you're finding out more as well. So we really appreciate you for sharing those new insights with us too. Thank you.
Thank you.
Right, ladies and gentlemen, it's my turn next. I'm going to be taking you through a deep dive on my why. And I think it's really important to understand why I've introduced treatments like EMFACE into my practice, how I combine it with facial injectables, and what I really saw was the future in my practice when it came to this. So I'm going to share my slide deck with you, a little bit about me. My background comes from reconstructive plastic surgery. I was a surgeon for 12 years in the NHS, predominantly in burns and skin cancer. And whilst I enjoyed treating patients with a scalpel to restore functional health, what really intrigued me about the science of anatomy really led me into revitalization and rejuvenation techniques. What lies beyond the scalpel? This has led me to open my clinic in Buckinghamshire, UK, where I specialize in everything non-invasive skin, face, scalp, and body. And I love enjoying regenerative treatments combined with energy devices and injectables to get beautiful results. So I want to go back to 2013. This is one of my patients. She's 49 years old, lost a lot of volume, and as you can see, she's deflated. And it took me up to about 13 syringes of facial filler back then in 2013 to get these results. Fast forward 5 years, again, another patient, accelerated aging. And it took 8 syringes of filler to get her to the middle picture, and a further 5, all at the same session, to get her to this point. It was at that point that I thought, I love the result, but how am I going to continue this into not just her future, but mine, but more importantly, hers? Are we going to keep using this volume of filler? How long are we going to use it for during her lifespan? Is it going to be sustainable for her? but most importantly, is it going to be safe for her as she goes into her 60s, 70s, and 80s? And I couldn't help but think about all of the layers of aging, the 5 layers from skin to subcutaneous fat, superficial to muscle to deep fat to bone. And I thought something was missing. It looked and it felt, and it certainly was, as if everything was detaching from the bone. And as you can see with Professor Cotofana's anatomy explanations, you can see the subcutaneous fat all attached by connective tissue. And it made me wonder, am I missing a trick as we approach longevity medicine practice today? So I go then forwards to 2017 when one of my mentors, Dr. Maurizio De Maio, and he said at Monaco one day, before trying to desperately make our patients look younger, we should first try to stop them from decaying, which really led me to think about how we should really be practicing dynamic and predictive aging. So now fast forward my time here at my practice, 2022 to now, really introducing EMFACE into my practice. And the answer is why? Is because I needed it. I needed it to bring this attachment back. And we know that muscle is the organ of longevity. If we can take that muscle and really pull it up, it is connected to the skin and it's connected to the skeletal template to really reposition and reattach, in my opinion, where everything should be. So I have all 4 applicators now, and these are the kind of results that I got in 2022. We got these kind of beautiful, safe, natural, pin-back results with our patients, and they not only look good, but they also felt great. They felt more attractive, they felt more confident, and I wanted to analyze and see how much volume restoration can we get. So I studied this using the Canfield 3D vector analysis, and when combined together, we got as much as 5 cc's of volumetric change. And as Professor Cotofana had said, the cheeks are the pedestal for the eyes and so forth. So 5 cc's of volumetric change back then made me think, wow, I wonder how long these results could last for with EMFACE. And we had Dr. Yael Halas who carried out the preliminary studies with EMFACE. And I also could show the same as Dr. Halas, that the results maintained for up to 1 year and now beyond with the addition of the new EMFACE Eyes applicators. So this is my personal experience back in November last year when I got EMFACE Eyes into my practice. And it was 20 minutes later, non-invasive, safe, needle-free, knife-free, downtime-free. And you can see it's improved my dark circles, my crow's feet, my light eye bags at the time. And I just looked so much fresher. Our patients looked so much fresher. And you can see it's in as little as 4 sessions, each session being 20 minutes long. This is the fast results that patients could see from a tightening, a tone, but also improvement in the lid-cheek junction. This is what they want to see. They just want to look refreshed, non-tired. So this is our latest patient from last week, male age 54, 4 sessions later. That is 1 a week, every week for 4 weeks. And you can see results like how I got back in 2018 with 13 syringes of filler. This is still an early result, but you can see he just looks well. And as you can see from the eye bag area, everything is restored, as Professor Cotofana had said, the infraorbital rim, etc. So I'll come to that later, but really it comes down to the legacy of the technology. I'm only going to invest in the best, and the best with data, evidence-backed journals, scientific evidence, peer-reviewed publications, and going back 31 legacy years of BTL's technology, from medical to physiotherapy to cardiology, coming into the aesthetic space. It was interesting to see the evolution of M-Sculpt, all those technologies, and now coming into EMFACE with the latest eye applicator. And what I really love about EMFACE is that you've got this combined radio frequency combined with high intensity focus electrical stimulation. And the beauty about the EMFACE eye applicator is that it's quick, it's non-invasive, it's recovery time-free, and it is precise. Professor Sebastian Cotofana just went through the anatomy of the area, and why choose the lower portion of orbicularis oculi is because it is the elevator. Instead of targeting the upper portion, which is a depressor, we don't want this to lower down. We don't want to get a brow ptosis. We want to get elevation of the lid cheek junction, because as orbicularis oculi weakens as we age, we also get fat prolapse. So why don't we tone the muscle, lift it up, prevent fat prolapse, and everything lifts as a result? I'd love to share with you a little bit about EMFACE. And EMFACE has been in my practice for 2.5 years now. It is a synchronized technology, combining radio frequency, which many of us have used for many years to date. Radio frequency, as we know, stimulates collagen, stimulates elastin now, as well as really improves the tightening of the tissues. Our patients want that. They want lifting, firming, tightening. But what this technology does, it also blends together high intensity focused electrical stimulation. It targets specifically the muscle and it bypasses the brain, and it works very differently to toxin. So it doesn't counteract the effects of our neurotoxin. And this is what it does. By bypassing the brain, it is causing a supramaximal contraction. A supramaximal contraction is something that our own bodies are incapable of doing, contracting the muscle delicately in this case to 100% of this capability. Professor Brian Kinney, who was part of the creation of EMFACE together with BTL, underwent peer-reviewed publications, and he proved through punch biopsies of the muscle that you get something called a 20-20-20, I say, which is a 20% upregulation of myonuclei. And this refers to the nutrition of the muscle. Isn't it interesting how you're not just contracting a muscle, you're also improving its nutritional state. And that is bringing more proteins and peptides and everything that's nutritionally good for the muscle for a long period of time. You're also getting a 20% increase in muscle density. So you're getting more fibers, which is really, really critical, 20% at the time. And the main thing to also think about is what we don't want to do is we don't want to melt fat. So this synchro technology keeps the heat at 40 to 42 degrees. This is optimum for collagenesis because we don't want any of these treatments to melt fat in the face, and I certainly don't. And the reason I bring a lot of these technologies into my practice is because ultimately I want them for me, and I certainly don't want to melt fat in my face. So what are we really looking at here? We're looking at a 30% increase in collagen formation. That is fantastic. And for the first time ever, we're looking at an improvement in elasticity. Now, we've never been able to target elastin production to this level, 129% increase in elastin. Now, collagen thickens, whereas elasticity improves elastin. So this is where the thin, delicate area of the skin around the eyes becomes very, very treated. Why think about collagenesis? Well, we lose 1% collagen, elastin, and hyaluronic acid as we age. What we see with EMFACE is a reboot of that collagenesis, but as we know, it improves over time. We do need to feed it, water it, love it, and light it sometimes, but this is something I'll come to next. So the synchronized radiofrequency heats this delicate tissue up to 40 to 42 degrees. As you can see from this diagram, the high phase is only located inferiorly and the radio frequency all the way around. So for the practitioners out there who are using EMFACE right now, just remember when you're using your right and your left applicators from the actual device, make sure you get it on correctly, or you might be doing the reverse, which is what you don't want to do. Now, we are focusing on the preseptal and the orbital portions only. We are not focusing on the pretarsal regions, and this is really important. When you target the pretarsal portion, you could cause an ectropion by turning the eyelid outward. So really be very careful when you're positioning your EMFACE eyes applicator by just targeting just above the orbital rim. Remember, you have the high phase in the middle and the radio frequency going around that. So you do have a couple of meters room for targeting the right area. What is it doing? It is improving eye bag reduction by toning orbicularis ocular muscle, giving you that 20%. And by contracting and contracting orbicularis oculi muscle, you're also flushing the lymphatic system. Now, I practice lymphatic drainage every single day in my practice, certainly before every injectable practice that I do, because we want to move unnecessary toxin as well as fluid accumulation in that area. And as a result, we get improvement in puffiness. I always say pre-treat the area, and this is where EMFACE Eyes comes perfectly into my practice to prevent this lymphatic stasis and dark circles. A lot of it is due to venous stasis as well as toxin due to staring at the screens all day and so forth. So I look at it beyond just the foundation contour and refinement. I look at it like the bricks and mortar, the cement, the groutings, the walls, but I also look at this like a plumbing and circulation issue. So EMFACE Eyes is able to do all of that. This is how the treatment works. The patient is on the couch. They have two applicators around the eyes. You can see the contractions coming. I will say it feels so comfortable, and it's done in as little as 20 minutes with no downtime, no redness, no bruising, no swelling, and the patient is absolutely fine to go home and enjoy the experience. So these are some of my results from just 4 sessions later. The beauty about radiofrequency, it can be used on all ages and all skin types because it is what I call colorblind. So it can be used in everyone. And the main thing that you can see is improvement in this lid-cheek junction. You don't see the infraorbital rim. So obviously, and the patients just look brighter and fresher. And when we got EMFACE eyes into the clinic, everybody wanted it. The eyes are such a key concern for our patients. And we got the first few applicators and it just went. So everything sold in 2 days. We had to call BTL very quickly to get more applicators in. And this is why I have 2 EMFACE devices in my practice, because I do believe it is a critical part for us to reposition the face first, and then for me to put my injectables in following this, because you're getting an improvement in muscle tone. You're getting an improvement in your existing superficial and deep fat pads, and then you're getting a repositioning fixed into place by the facial fillers. I can delegate this to my amazing team who are out there who've helped me produce these results today, and I can feel safe that everyone is able to do so with some adequate training by BTL. So this is where it falls into place. We now have 4 applicators for the forehead. Professor Cotofana has talked about the frontalis muscle lying in a hammock. So when we tighten frontalis, everything comes up with it. And then next, we also have the cheek applicators, which, as you know, works not only through the skin, but it goes through all the connective tissue, through the fat, and repositions SMAS. And when we do that, we're getting a repositioning of the cheek as well as the jawline. And then the third applicator that came through last year was for the submentum area. And we're getting a tightening of the anterior bellies of digastric muscle. We aren't able to get to the 2 anterior bellies of digastric until we go through a deep plane facelift. So for the first time, we're able to offer our patients non-invasive to get that cervical-mental angle and jawline looking very sharp and very tight. And then now this year, launching to you the eye applicator, which we're super excited to share with you today. I want to share with you this critical slide, and Professor Cotofana described this beautifully. Why does the cheek come up, and why does the midfacial fat in the cheek restore? And this is because of the transverse facial septum. The transverse facial septum connects to the deep malar cheek fat pad. And when we tighten this with the cheek applicator, this is why you get a restoration of the fat pad. The patient looks more tight, they look more attached, the lid cheek junction is improved, and everything about the patient looks so much more improved. We can see this time and time again with our patients. And when we first started all 3 areas, it was so clear that there was just one thing missing, and that was the eyes. So this was an easy introduction into our practice because patients wanted it. It was the last thing that was needed in our practice. And then I look at my older patients, and this is really interesting because we look at the 12 hallmarks of aging. Our patients now are going into their 70s and 80s. We know that they're undergoing immune decline. We know that they're also having microbiome changes. Many patients are now ill for a lot longer. Do I really feel comfortable injecting them with large volumes of filler? So the answer is I start off with EMFACE. I reposition everything back into their facial tissues and structure. And then I use autologous fillers, such as PRP filler, in order to restore volume. And this correction is so much more safer, it's so much more reliable for me because it also integrates them beautifully together with EMFACE to deliver these results. But look at the final area that we haven't quite tackled yet. This is where EMFACE Eyes comes into place, and I look forward to sharing the results with you soon. So ladies and gentlemen, look, we know so much about skin aging. We know about skeletal tissue aging. We now know about muscle aging in the body as well as the face. So when we think about addressing predictive aging, which is what we should be doing nowadays, we can think if this is a young girl at 25, and this is the kind of result that she got in just 20 minutes, when we thought she didn't need anything at all, we can see she is lifted. So why not think about this sort of approach across the board for all of our patients? And I go back to this gentleman who's only 54. Why not introduce a treatment like this to lift, to restore, to regenerate all of his connective tissue, to bring him back to where he used to be? So this is only a 1-month-old result. I look forward to what's to come. So for me, it can be applied to everybody, EMFACE and EMFACE Eyes in all of the areas. We can treat 100% of patients, male, female, for all patients who want needle-free objectives, where we're getting to that tipping point with our injectables where we don't want as practitioners to do anymore. And as well as our post-facelift patients, it certainly does extend the longevity of the patient and the longevity of the facelift, because I want my patients to age as well as they can, for as long as they can, for as safe as we can. But I do have a little bit of homework for patients. Feed it, water it, love it, light it. Drink more water, move, manual lymphatic drainage, do more exercise, get good sleep. It's really important for people to do that. I put positive emotional well-being because a lot of patients are going through a hard time right now with bereavement, feeling negative. So I say, look, this is not something for patients who are currently crying right now. We need to kind of like move forwards, as well as to use good eye care. So for me, EMFACE fits critically in all of my treatments, from skin to face to scalp to body. It is delegatable, it's safe, it's easy, and it's done in as little as 20 minutes. And the most important thing for those out there who haven't felt it yet, feel it, because it's the one treatment that I do that makes people feel really good. I look forward to receiving your questions at the end of the webinar, and we look forward to our next presenter as well. So without any further ado, I am so delighted to introduce to you Dr. Melanie Palm. Dr. Palm is a board-certified dermatologist, and she is from the San Diego, California area. She is the founder of her beautiful clinic, The Art of Skin MD, in Solana Beach, California. She's the assistant clinical professor at the University of California, San Diego. She's also an affiliate staff physician at Scripps Encinitas Memorial Hospital. She has a beautiful practice and a fantastic, gentle, artistic approach to her patients. And I'm so excited to welcome her to you to share her protocols on injectables and EMFACE eyes. Thank you, Dr. Palm.
Thank you, Dr. Balaratnam. And, this is our first opportunity to work together. And I love that you are half the world away, and we all need to give you thanks and a round of applause, because I think it's like midnight your time, which is phenomenal. But I think despite that distance, great minds that I think are thoughtful about our approach to patients, we often come up with similar theories and processes. So I absolutely love your presentation. And you've got a little bit of a head start because you've had this lovely device in your hands a little bit longer than we have here in Southern California. But today I wanted to share with the audience our experience with being one of the 3 clinical investigators in the trial here in the US to look at this new application for EMFACE. Our clinic's history with EMFACE is we were one of the first in the US, and I think maybe the first in California, for sure in Southern California, to have EMFACE. And it really has, like a couple of other sort of procedures that I perform in my clinic, I think foundational to really beautiful results in our patients, undetectable, which I'm glad to see that the pendulum is sort of swinging towards a very natural, authentic look, one that has restraint. That's something that I've preached for a long time. And I love this applicator too, because as we all know, the eyes are the windows into the world. One of my sort of favorite scientific stories to tell of why that's important dates back to a Russian scientist named Urbis. And back in the 60s, I think it was 1967, he actually did studies on visual tracking of the face. And when we are assessing a new face, what do? We go eyeballs, 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 maybe to the nose, finally to the lips, then the perimeter of the face, and we go back to the eyeballs. So I think the periocular area is so vitally important to the work we do. And that's why I'm excited to talk about some of the preliminary results of what we're seeing here in the US. So you've already gave me a beautiful background, so I won't belabor that. I do sit on the medical advisory board for BTL, and I was involved as one of the 3 clinical investigators for EMFACE eyes. And here's some of our original results. We are really just tying up this study. And so it was a 3-site study. It was myself, Dr. Kilmer, as well as Dr. Gentile. And we are following patients out and sort of finishing up final results, but we wanted to present at this meeting today the 1-month results. So what was the study design? Each site had 10 patients, so we had 30 patients total. They received weekly treatments of 4 EMFACE eye treatments, which is a 20-minute treatment with little to no downtime and prep, as has been explained by Dr. Balaratnam. And then we looked at several factors. We wanted to look at eye bags, crow's feet, as well as dark circles. And there was a high measure in terms of the severity of some of these manifestations in the infraorbital region that was required for patients to qualify for this. So they really had to have pretty moderate to severe manifestations of eye bags. So I think I love seeing the spectrum of results that we've seen in the previous presentation, because I think Dr. Balaratnam chose some milder cases, and I think those younger patients in the milder cases benefit just as much as the more significant severity types that we saw in this study. So what were some of the results? Well, first and foremost, high patient satisfaction. I actually had my first treatment last night because I wanted to come well informed. We are now able, starting in April, hopefully, fingers crossed, to start treating patients outside of the study. And it is a comfortable treatment, and I think that's reflected in the patient satisfaction, not only in the effectiveness, but also the comfort and the little downtime to no downtime patients have from the procedure. But what were some of these initial results just at 1 month? And I would expect these to be even more significant at the 3-month mark. Well, there was over a milliliter in difference in the eye bag, so reducing that volume in the infraorbital region, a 28% reduction in the crow's feet area, and the luminosity of the skin by us biologically affecting the muscle and helping with collagen and elastin production. We saw a dramatic improvement in dark circles by a 64% reduction in that region. So here are some of the results of my own patients. And in this case, this is a 61-year-old. Again, we were looking for patients with moderate to severe eye bags, and you can see that she's sort of on that spectrum. And what we see in general is improvement in sort of how light is reflecting back to our eyes. So we see improvement in the severity of the darkness in that region, and we also see a volumetric reduction in that infraorbital fat pad. Here's another patient. She's even more senior, and we actually wanted to enroll the daughter in this study, but she has milder changes. But she is in this case, the apple does not fall far from the tree. She looks like a mirror image of her mom, but just a younger generation. And what do we see with her? I would have you look at some of the inferior crow's feet. So those lateral canthal lines that are in a more inferior position, you see a dramatic improvement in that area. Crepiness in the under eye, improvement in not only the infraorbital fat pads, but some of the festooning in this area. We see an improvement as we've been able to tone the muscle. And in addition to that, you can see that area that we sometimes treat called the jelly roll being improved singularly with this treatment. I think she really is a reflection of what we holistically see with patients that have had EMFACE treatment to the eyes, which is improvement volumetrically in the eye bags, improvement in how light bounce and the dark circles are being reflected back to the viewer, and then improvement skin texturally in the crow's feet in the medial or lateral and inferior region that we're treating. So this is that same patient looking at volumetric changes, and you can see the heat map shows intensity of where that's the greatest, and it really is where we want it to be. So centrally concentrated where we see the most volumetric change in the infraorbital fat pad is reflected by more significant reduction in that fat pad with treatment. So I think these results are super impressive. I could not wait to be complete with this study as a clinical investigator and for this to be sort of pushed forward in the US so that we could actually administer it, when appropriate, similar to Dr. Balaratnam. I do love to do a treatment so that I can personally express to patients how a treatment is, how it is to experience it as a patient. And the procedure is very straightforward and it's comfortable. And it is one of those things that I explain to patients. I know that oftentimes in life things seem too if they're too good, it cannot possibly be true. But I actually think that this particular procedure is an exception to that rule. So how do I anticipate that this is going to fit into my practice? Because again, we haven't been doing combination treatment with this, but we have had EMFACE for a little over 2 years in our practice. And I will share at the end a couple of these sort of whole face long-term treatment outcomes that we've seen with our own patients. So when we're talking about the periorbital area, and I'm thinking about just injectables, so I'm kind of putting aside energy-based devices, things like lasers, like ablative lasers that we sometimes use in the infraorbital area to address textural issues and skin tightening. What is my approach? Well, typically, it's very conservative HA filler to that area. I have been a part of the 3 major clinical trials that were pivotal trials that led to FDA approval currently for the 3 FDA-approved products in the tear trough region, being Volbella, Belotero, as well as Restylane. And really, again, restraint, I think, is key. We do not need a lot of volume in this area. It should be delivered, as Dr. Cotofana mentioned, in the supra-periosteal plane and nowhere else. And it really should be something that we are thinking about compartments around that area. So when I am looking at the under eye area, actually my eye first goes to what's going on with the temple. Do I need to support it deeply or a little bit more superficially into the hairline? Do I need to support the mid-face, both with support to the SOOF, these deep fat pad compartments, and sort of how is that playing a role, and how is that communicating to the under eye area, and how can I sort of soften these areas of cosmetic demarcations in the face? When I think of botulinum toxin to the eye area, and we have been a part of lateral canthal line studies for botulinum toxin type A here in the US. Again, if you were to use on-label dosing of something like onabotulinum toxin to the eye area, I think in many patients you are wiping out their orbicularis entirely, and you're losing part of the Duchenne smile, part of that authenticity of our smile that emanates from the periocular region rather than from the mouth itself. And so my approach when I am treating the lateral canthal lines around the eye is I use it mainly superiorly for a brow lift. And then I look at the fan and I treat that, but I'm very careful that inferior to that sort of horizontal line of the lateral canthal line, that I am treating with restraint and very few units. So for myself, if I was using a product like onabotulinum toxin, I only use a couple of units in that region that's sort of inferior to the lateral canthal line, because I want that corset that is the orbicularis inferior to our lateral canthal region in order to sort of hold the contents of the fat and maintain the tonicity of that under eye area. If we are too or less judicious in what we're doing, then you see a relaxation of that corset, and you can see infraorbital fat herniation, skeletonization, where you see infraorbital hollow show, and it's very unpleasing and it makes patients look tired. The final thing that I do a lot of from an injectable standpoint is regenerative. I think that's one of the reasons that I'm such a proponent of EMFACE, is because we finally have a way to non-surgically regenerate the muscle compartment in the face. But I also love PRF or PRP in this region as well. And I use sort of a 2-layer approach in this region, supraperiosteally and just under layer 1, as a regenerative area, an autologous source of support that we can actually treat up to the lash line. And this is something I would anticipate that I do in combination with EMFACE as well. So dermal fillers, what's my typical protocol? I sort of explained this, I think, in the previous slide, but really we want to restore and create structure in these areas. I tell patients that, you know, the sides of our face should be similarly looking brothers or sisters. They shouldn't necessarily be twins. I think a little bit of asymmetry is what creates authenticity in our face. It's what characteristically makes us us. So I don't try to totally take that away, but the purpose of fillers should really be able to support the foundation around the eyes, and then with restraint if needed, I do use fillers, but we don't want to use it if patients have true infraorbital fat pad herniation and under eye bags. These are patients that traditionally, prior to the introduction of this technology, I would work hand in hand with an oculoplastic surgeon for them to help with reduction in that region and replacement of fat pads if appropriate. And really shouldn't be the place of fillers to try and obfuscate and camouflage that region, because although it may look beautiful initially, I think it can be problematic down the road. And I think, you know, there has been such a social media tide for sort of patients wanting a very natural and toned look, which I think has always been our aesthetic, and really the time of just sort of multiple syringes and a too generous sort of spoonful of fillers has now passed, because we want to avoid that overfilled syndrome. So in general, I do feel that this is a very delicate region. As Dr. Cotofana went through the anatomy, there's a lot of anatomy to digest, to understand, and really be processing if we are going to treat this under eye region. And you need to keep that in mind, and you need to be very well versed. And for this reason, it requires an expert hand in order to deliver fillers in this region of the periorbital area. And one of the reasons that we get most concerned about is the vasculature in this area. So high risk complications, we want to avoid a vaso-occlusive episode. I was talking to a colleague who had been referred a patient that came to them that gave a history of getting, and this particular injector really should purchase a lottery ticket, because this is unbelievable, but managed on both areas to cannulate the infraorbital arteries and cause bilateral necrosis of the cheek region due to a vaso-occlusive episode bilaterally. And so these are the things that we want to avoid. In the worst case scenario, that we know there's such a rich anastomotic network around the eye, and there is a very minute, but there is a risk of blindness that we need to keep in mind. And I think I always get concerned when people are very confident coming out of the gate. I think the mix of bravado and ignorance is one to be cautioned. And I think as you become a more advanced injector, you do have some reservation, and as you should. The anatomy is complex, and it's very varied depending on the individual. Other low risk complications that I think we obviously see more commonly is, I will have a patient come in, they haven't had filler in 5 years, they're new to me, but the product is still there. We know these from blepharoplasty patients, when the areas have been dissected, that for 5 to 10 years that filler can be persistent, and this can cause that bluish discoloration in the area. But I think what we see probably most commonly is lymphatic obstruction and compression in the area. And so for this reason, I think we need to be very thoughtful, and again, small amounts if we're using dermal fillers in this region. So how do we use EMFACE to create sort of more predictable results? Well, similar to the approach of Dr. Balaratnam, I think as I start to introduce this into my practice at large, this will be a toning device that I use first to really help that corset in the under eye region. And then from there, we can think about how do we support that structurally if we're using dermal fillers or collagen stimulators. And there's several areas, if you look at this diagram, where filler has been placed, but I think several of them we really want to avoid. I think Sebastian so elegantly outlined that preseptal space of fat, and this is an area that we do not want filler to exist. In the studies, in the FDA approval, the proper placement of fillers is on the supraperiosteal plane, and that really should be the only one. We don't want it sitting above that region. And then in the mid-face, obviously, providing some support in the SUF is appropriate as well. So just touching on this, I think with EMFACE, you have an opportunity in your clinic to do a fully delicable procedure that is predictable and is comfortable for patients, and tones that muscle and creates beautiful outcomes that I think are truly regenerative. And so I think this will certainly be something that I introduce on a regular basis into my armamentarium when I'm thinking about an approach to brightening the eye area and helping with periocular rejuvenation. So how about my approach to neuromodulators? Well, this is a patient that has facial asymmetry, and so you can see that the toxin doses that are being delivered are different depending on the area of treatment. But in general, as I spoke about sort of at the beginning of the talk, we really want to focus on sort of lifting the brow and softening some of the crow's feet, but not taking away some of that sort of contraction that is powerful and can be utilized in the infraorbital region to help sort of strengthen that area and help with the lid-cheek junction. So reasons to avoid fillers in this under eye area is because we can get, if we're over judicious in the use and we over relax with toxin use, we can see that protrusion in that area, and it impedes some of the lymphatic drainage. So just as a call out, again, I think restraint and thinking about a multimodal approach is best. So again, just to summarize in terms of EMFACE and the use of neuromodulators, this really can be used in conjunction with one another. We can use the neuromodulators in the superior portion of that lateral canthal line region and help that to lift the brow and treat some of the crow's feet, while we can use EMFACE to help reduce some of the eyelid bags, to help with dark circles, to improve the texture of the under eye as well. So just a couple of, I know we want to leave time for some questions, but just to show a couple of combination treatments in my own patients. Again, this is without the EMFACE eyes, but looking at a patient that's a combination treatment, again, using a little bit of product, a collagen stimulator in the lateral face that's lateral to the true ligaments of the face, a bit of cheek filler to the SOOF, and then some strengthening in the lateral jawline, and combining this with treatment in the midface and in the submentum with EMFACE. And this is another view where you can see beautiful improvements, a return to the OG curve, improvement in the volume of the cheek without really adding anything to the medial cheek volume, but just again with repositioning with better muscle tone. And then finally, this is a patient shown in her baseline that was 12 years ago and how she exists today. And we've done very little, but just consistently on her, really in the lateral face with collagen stimulators and a small amount of cheek volume and some support in her perioral region with fillers, but have done consistent toxin use, and she's now had full face treatment. So upper face, mid face, and then submental treatment with EMFACE with very beautiful results, an eye-opening look. She has a more relaxed look. She looks quite sort of angry, which is not her personality in her baseline, and looks more refreshed now today. And so with that, I am going to hand it over to our MC, Dr. Balaratnam, and I think we're going to field some questions.
Thank you very much, Dr. Palm, for such a beautiful presentation. And I'm sure everyone can agree that your results are exquisite. Your patients must be over the moon, because there is absolutely no distortion of facial features. The results are, she just looks like a younger version of herself, but she's much older. Having a combination of the treatments together, you've managed to beautifully relax the depressors, and you've worked with correcting facial volume, and then you've augmented with the muscle and the skin. So this is exquisite. We've got so many questions here, and I will direct them to each and every one of you. And if you could chip in, that would also be great. So there's been a number of questions here questioning whether EMFACE eyes prior to surgery would offer better results. And I'd love to ask Dr. Cotofana first, actually. Professor Cotofana, when you've dissected the infraorbital area in your dissections, at roughly what age would you see a herniation of the fat pads, just so that as injectors or EBD users can get an idea when to start treating?
Yeah, that's actually not a very easy question, because unfortunately it highly varies. But a couple of things that we need to consider when we see palpebral bags, kind of like the protrusions, and for this we always need to be mindful what causes this. So normally the lower eyelid has three containment structures: skin, muscle, and the orbital septum. So these three components work together to keep everything that's inside the orbit inside, and to allow for a smooth transition between the lower eyelid and the cheek. But as we mature, skin gets thinner, the muscle gets weaker, and the muscle, what happens to the orbicularis muscle is when we're young, the muscle looks like this. But when we're older, the muscle starts to look like this, with fat in between and connective tissue in between. And this decreases the containment forces to keep everything where it is. And then in addition to this, starting with the age of 30, unfortunately, it happens, which we call the bone remodeling of the facial skeleton. And what happens is, and you know this best, all from clinical experience, the piriform fossa goes to the back, and then the height of the midface decreases. So in other words, everything here in the midface kind of loses its support, follows the effect of gravity. But then something else happens, which I rarely talk about because, I mean, it's too complicated. What happens is the orbital floor. When we're younger, the orbital floor is almost horizontal, but as we age, the orbital floor inclines, resulted by the recession of the maxilla. So it rotates like this. So piriform fossa goes to the back and the orbital floor goes downwards. And this is also why the inferior orbital rim, we know this kind of like descends and enlarges, especially this area. It's kind of like, it's exactly this movement. But when this happens, everything that's inside the orbit is prone to move more anteriorly because it's gliding down. It's almost like a swing, kind of like it moves downwards. And when you have less containment forces in the front, it pushes against it and then it bulges. This is what we call a pseudoprolapse. Now, the question is what you want to do. You need to find the proper time when the containment forces can still be strengthened enough to push it back. But when this is not applicable anymore, what happens is then you need the surgical approach to open this, reduce some of this fat, and then you can have this retainment forces. But I don't think that one excludes the other. Sometimes you can maybe even do the surgical procedure first and then to tone it in more mature patients, or in younger patients, maybe you can do more of the toning procedure to prolong and to push the surgical feature out as long as possible. So this is why, I'm sorry, long answer for a complicated topic, but I would love to have yours and Melanie's input on this topic as well.
No, thank you very much for that. And just going to you, actually, Dr. Palm, that's one question that has been asked in the chat box. How would you utilize EMFACE and EMFACE eyes pre-surgery as well as post-surgery? Any protocols to share?
Yeah, I think one of the lovely things about being on the medical advisory board is you get to sort of share your experiences with such a lovely think tank. I mean, just amazing minds. And I love that it's a mix of specialties and we sort of exchange ideas because some of us are non-surgical focused. Some of us have a very vibrant surgical practice. And my approach has always been sort of first and foremost, see where the patient is at. Because sometimes you have patients that are surgical candidates, but either their medical history proves that this is not the time to do it, or they are just not mentally ready for that. And so you need to offer an alternative to that. I think in speaking with some of my plastic surgery colleagues, the best analogy that I love from them is that this is almost like physical therapy prior to surgery. And then you continue that afterwards. And so I tell patients, I was just speaking to someone yesterday, they were new patient, they are in the health space, they're online and have a large presence. And so we could talk at a really high level because she understands the concepts of sarcopenia. She's into the longevity space. So, she just, we were but being able to sort of, I told her, look, you'll go through an initial series of treatments, but same as if you were training for something in the gym, you wouldn't certainly just say, okay, I'm done. I did my 4 treatments and that's forever. So I tell patients there's some sort of maintenance involved. And so I think if you are wanting to be in the best shape you can for the surgeon, I love the idea of pre-treatment if physical concerns are not a concern, because you're sort of like, it's your pregame getting ready for surgery. And then I think to help with the span and the longevity and the long-term results of the surgical outcome, then continue to do that to maintain that, because we know that we're living in a very dynamic space and aging is continuing to happen. And we can do things to sort of, from a regenerative space, intervene and keep us at a very good point.
Yes, I completely agree. And I think that extension into a maintenance series actually benefits patients and they love it. They feel it, they see it, they love it. And coming back to a maintenance therapy, do you have any set protocols, whether it's 3, 4, 6 monthly? We have a number of questions here that I've asked that.
Yeah, and I know there was a question about like how soon after surgery could you do that? I'm actually going to defer that maybe to you. I would always defer to the surgeon, but I would say probably 3 months for me. A month seems a little bit early, but I'm curious what your thoughts are sort of post-surgical, but I would defer to the treating surgeon in that respect. In terms of number of treatments, what we've sort of developed for EMFACE with other applicators is it's age-based, just in the way I think of collagen stimulators and the where somebody's sitting in the aging spectrum and sort of the volume deficit that we have to make up from in the craniofacial support and soft tissue support that we're trying to accomplish. I think about that with sarcopenia in the face. So if somebody is coming to us as a 30-year-old or a 40-year-old and they have maybe sort of more genetic sort of manifestations that are causing the issue that they're wanting addressed, we typically, because their cellular machinery is better, I think that they're going to respond and they're not starting at such a deficit. We would stick to sort of the 4 treatments, and we typically will do that once to twice a week, depending on their schedule. If they're more advanced in age, or we see a more sort of severe phenotype in terms of the infraorbital issues that we're dealing with, then that's typically where we recommend 6 sessions, and we've seen very nice outcomes from that. And then I think it's up to the patient. I mean, we usually recommend we know from prior studies with EMFACE that results are maintained through 6 months, but we really encourage patients to do at least 6 months a maintenance treatment. And for those that are really enthused, we've had people do it even quarterly.
That's a great point. Thank you so much for sharing that. I have a very similar protocol here at the clinic. When we first started off with EMFACE, when it came to a patient with a slimmer face with not much jowling and not much descent, the protocol of 4 worked really well for me. And we reviewed our patients every 3 months to check in with the results. And with a patient where we didn't touch her for a year, she maintained her results beautifully. But what we saw an extension of the result and more lift was when we repeated it every 3 to 4 months. So that gave us a lot of success. And similar to you, where a patient was more mature, there was a lot more heaviness in the face. We carried out a series of 6 sessions done back to back, 1 or 2 a week, and they did incredibly well. So I think for those practitioners out there, I think really just examining your patients, listening to them, as well as finding out how the surgery went, if they had surgery to begin with. And I think that's really, really key. We have time for one more question, and this one is about the use of calcium hydroxyapatite and combining biostimulator injections together with EMFACE. Any protocols for that, Dr. Palm?
I think if we're getting patients sort of natively and they are willing to be a little patient, I'm very similar to you. I like to put structures in place first and get that sort of anti-gravity effect and get muscle toning in play first. And then I would go back and volumetrically help them with your collagen stimulator or your filler of choice. And in this case, it sounds like the patient is, the person is referencing CAHA. So I would probably do it after. I wouldn't do it in combination. I love combination treatment, but to minimize adverse events and downtime, I typically separate out treatments. So I would try and complete the EMFACE treatments first, and then I would use the calcium hydroxyapatite afterwards.
Wonderful. Thank you so much, Dr. Palm. And the final question is to Professor Cotofana. We have a question here, Professor Cotofana. Given the similarities of smiling, will muscle contractions from this type of treatment lead to more smile lines?
Thank you for giving me all these easy questions, which I'm very happy about. So what actually my first impulse on this answer would be actually it will reduce the presence of smile lines. And for this, I would like to mention one study that we just recently published in which we treated facial overfilled syndrome with hyaluronidase. So patient in that study, I think it was 28 patients, they complained about an unnatural smile and over-volumized cheeks. And what we did in those patients is we measured the position of the corner of the mouth, and then we found respective measurements. And then we dissolved this with around 80 to 85 units of hyaluronidase. And then after the treatment, the corner of the mouth was able to be moved more lateral and more upwards because there was less volume here. So it was more kind of like smile possible because there was less structures or less volume blocking the contractions of the transverse facial septum. But in addition to this, we also found in those patients that after a treatment of the overfilled syndrome, after the injection of hyaluronidase, the severity of crow's feet reduced. It got better. And the answer to this was, when we smile with multiple muscles, including the orbicularis. And when there's a lot of volume in the mid-face, what happens is the orbicularis works a lot to pull these structures up. So we have a lot of lines because the muscle works a lot. But when we support the muscles, then the muscles don't have to work that much, and this will reduce their respective wrinkles. So the same concept also works on the forehead. When you tone the sleeping bag, in which the frontalis muscle is included, then the frontalis muscle has to work less, and this what results in less lines. Kind of like totally differently when you think, oh, but I'm toning the muscle. A stronger muscle would have more lines. No, no, no. You're toning the sleeping bag. Same thing here. You're toning and you supporting the containment forces. And with this, you're also reducing the workload of the respective orbicularis muscle.
Thank you so much. You made a difficult question very easy to comprehend, Professor Cotofana. Right, ladies and gentlemen, I think it's a wrap. I would like to say a huge thank you to all of our hundreds of attendees for your many questions this evening, for such a high level of engagement for this evening's webinar, all about periorbital aging, periorbital treatments, and how combination treatments really are at the centerpiece of everything that we do as practitioners. And I would like to say a big thank you to our esteemed speakers, Dr. Melanie Palm, all the way from the US, as well as Professor Sebastian Cotofana from the US too, for your key insights into this treatment and on facial aging and anatomy. And a big thank you to BTL for the opportunity for all of us to share our experience with you. Good morning, good evening, good night, everyone. Thank you and good night.
Bye.